Now, when students ask me, how do you synthesize adenine? What does adenine need for synthesis? Which group? What does adenine need for synthesis?
Amino groups.
Amino group, that's all. So please don't get lost in this reaction. Just look at the structure. Don't even draw them. And you will know that, okay, adenine needs an amino group. But have you also heard about these minor purine bases, hypoxanthine and xanthine? Which pathway keep the right intermediate in the right pathway? Purine catabolism. Purine catabolism, you learned them. You didn't learn them in these minor bases, you learned them in purine catabolism. And then did you do the enzyme xanthine oxidase? So see, I'm bringing to your attention, I know my purines, okay, adenine, guanine. I know hypoxanthine, xanthine, but now where did I learn them, right? And what do they need for synthesis? Rather than getting lost in the reactions. Then bring in clinical stuff. I'm not saying you should not bring clinical stuff. This exam is clinical, but you got to go back to the step, right? When you compare thymine, cytosine, and uracil, tell me which one requires a methyl group? Thymine, cytosine, uracil. Which one requires a methyl group? Thymine. Then you got to jog your brain. Some students are finding difficult to know the vitamins or cofactor. So tell me, who all can carry methyl group? Who all can carry methyl group? Give me a methyl group donor. Sam. Sam. Very good. What else? Sam.
Folic acid
Cobalamin.
derivatives.
Sorry?
Folic acid derivatives.
Yeah, or tetrahydrofolate. So when you say B12, it should be cobalamin. When you say folate, its active form is tetrahydrofolate. So I would say the right list is Sam. Sam is not your next door neighbor. Then methyl tetrahydrofolate or tetrahydrofolate and cobalamin. These three are your methyl group carrier. But tell me, who works here? Who works in thymidine synthesis? Sam, methyl tetrahydrofolate or cobalamin? Who directly helps thymidine synthesis? Folate, B12, or SAM? So folate. So you get my point. This is how you get your right vitamin and right place. But in B12 deficiency, do you see folate trap? In B12 deficiency, do you see folate trapped? I will tell you what is folate trap. Yes. So indirectly, B12 deficiency can also affect thymidine synthesis. But first, primary. Direct, if you should know direct first, primary first, secondary later. So primary, who will be helping thymidine synthesis? Tetrahydrofolate. Can B12 deficiency also affect its synthesis? Absolutely. Can SAM defect affect its synthesis? Can a defect in SAM affect thymidine synthesis? Yes or no? Can SAM defective affect thymidine synthesis, which is this one? Yes or no? Anyone? Can a defective? No. You got to be very clear. Sam is not your next door neighbor and is not employed everywhere, right? So no, SAM defect will not affect thymidine synthesis. So should you know that that tetrahydrofolate carries one carbon group? Absolutely. Dr. Panini has mentioned these two forms. I don't really want you to know these forms, but yes, for methyl group, it's tetrahydrofolate. You just said cobalamin and SAM, right? Are you clear with that? So there you will bring your vitamin. So for folic acid, do folic acid, do purine, pyrimidine? Can you complete the list? What do folic acid synthesize? Purine, pyrimidine. When you say THF, it's active form of folate known as tetrahydrofolate. So when you say tetrahydrofolate, what does it synthesize? Purine, pyrimidine. Can you complete the list? Methionine. So don't flip-flop that. In folic acid deficiency or tetrahydrofolate defect, or in case of B12 deficiency when there is a folate trap, can you do methionine synthesis? Can you do methionine synthesis when there is a B12 deficiency or folic acid deficiency? No, so you have got to be very clear what are they used for. I have also mentioned them. So are you aware, first of all, of these two, that both of them, the methionine synthesis require both folate and B12? Yes? Does methionine synthesis require both folate and B12? Yes, so you got to absolutely know where they are working. Yes, folic acid is also used for purine, pyrimidine, and succinyl-CoA synthesis. What is this pathway? What is this pathway, succinyl-CoA? Have you learned this pathway? Is it a multi-step pathway, requires multiple vitamin? Everybody vomits, right? Everybody vomits. So it's a methylmalonyl-CoA. It's a, propenyl-CoA, methylmalonyl-CoA, succinyl-CoA pathway. SAM is not employed in thymidine synthesis. SAM is employed other places. Also, I want you to bring your attention to macrocytic or megaloblastic anemia. Are all of them responsible for macrocytic or megaloblastic anemia? Yes or no? I hope you're following my pace. Are you following my pace? Everybody's good? Okay, great. I just don't want to run fast. Please, if you have any confusion, ask me. So are you aware of all of these three having macrocytic or megaloblastic anemia? Is there any confusion in that? All three will have macrocytic and megaloblastic anemia. So this is what you got to do. If there is a megaloblastic anemia, will you pick albinism? If there's a megaloblastic anemia, will you pick albinism? No. So you got to know the list where you have macrocytic or megaloblastic anemia. Then you go, is macrocytic? Yes, macrocytic is same as megaloblastic. Macrocytic is on the MCV. More than 100 factoliter is macrocytes, but they also are immature cell with large nuclei, so they are known as megaloblast. So macrocytic and megaloblastic, yes, represent folic acid, a B12 deficiency, a UMP synthase deficiency. Then you got to ask yourself why. Why you have a macrocytic or megaloblastic anemia in B12 or folic acid deficiency. So is this methionine synthesis requiring both B12 and folate? Does methionine synthesis require both B12 and folate? Yes, but when B12 is deficient, the folate is trapped. This reaction does not happen. How is folate trapped as? Methyl tetrahydrofolate. Tell me, is this good? Is it okay that folate is trapped? No, but folate trap is not seen in folic acid deficiency. Folate trap is seen in B12 deficiency. Either way, which is the next slide. Either way, if you have low folate in the diet, if you have a low folate in the diet, pregnant females, low absorption of folate, or B12 deficiency where you will see folate trap, not free tetrahydrofolate, which synthesis will decrease in both folate and B12 deficiency? Purine, pyrimidine, as well as methionine. Does that make sense? Whether it's folate or B12 deficiency, all three of them will decrease. So is low purine, low pyrimidine, low methionine differentiating folate from B12 deficiency? Is low purines, low pyrimidine, and low methionine differentiating folate from B12 deficiency, these levels? No. So then you got to go and find out how you can differentiate folate from B12 deficiency. But low purine and pyrimidine are responsible for macrocytic or megaloblastic anemia in both folate and B12 deficiency because nuclear maturation lags behind cytoplasmic maturation. Does that make sense? So is folate essential for thymidine synthesis? So is folate essential for thymidine synthesis? Yes. So you got to bring your drugs too. So can methotrexate intake reduce thymidine synthesis? Some people tend to forget this, that folate is essential for thymidine synthesis. So can methotrexate intake also reduce thymidine synthesis? Yes, you got to be mindful of that. Secondly, methotrexate is an anti-cancer drug. And anti-cancer drug usually act on three metabolism: folate, like methotrexate, purine, and pyrimidine synthesis. Why? You got to kill these anti-cancers. You got to kill the cancer cells. You don't want them to exist, right? Your target are cancer cells. So three places your anti-cancer drugs act: folate, purine, pyrimidine. Methotrexate is an example of inhibiting folate, which is folate reductase in eukaryotic folate system. So you got to understand, this is my step, this is where folate is required. Then you bring in your drugs. So methotrexate, yes, can indirectly inhibit thymidine synthesis. Don't forget that. Bring all your drugs. Secondly, ribose and deoxyribose. Remember, I told you, I'm sure Dr. Kamath must have talked about this. When you convert ribo into deoxyribo, is it oxidation or reduction? Ribo into deoxyribo. Ribo, it is reduction. So this is the enzyme which is ribonucleotide reductase, also known as RR. Its natural inhibitor is deoxy ATP. Natural inhibitor or feedback inhibitor is the product. So what I'm trying to bring to your attention is, okay, these are my purines. How can I synthesize them? What is ribonucleotide reductase? You got to be familiar with the reaction steps and then go to drugs. Does that make sense? But don't forget drugs or clinical conditions either. Some students are confused between nucleoside and nucleotide. I hope you know nucleotide is what? When you're saying I'm doing de novo purine synthesis, actually you're doing de novo purine nucleotide synthesis or de novo purine pyrimidine nucleotide synthesis. So what is a nucleotide? Base, sugar, and phosphate all should come together. Base, sugar, and phosphate. All of them should come together. Yes, nucleotide also has a phosphate. So let's see how you should do them now. So you should be familiar with these terms, please, before you jump to these pathways. They will help you understand, okay, this is what I need to know. So please do purine versus pyrimidine. Please do synthesis versus catabolism. Absolutely compare de novo purine. Absolutely compare de novo purine with de novo pyrimidine. For example, CPS1 is rate-limiting enzyme for de novo purine or de novo pyrimidine. CPS1 is rate-limiting neither. I like that. You are awake. I'm glad. You had your breakfast too. Neither. You got to understand. CPS, somebody said pyrimidine. Wake up, wake up. No. When I'm saying CPS1, it's neither for de novo purine, neither for de novo pyrimidine. It is for urea cycle. And it has a different activator. Understand that. So you can mess that up. Okay. So compare and contrast de novo purine versus pyrimidine. But I've told you first do catabolism and then do salvage. Why? Because catabolism releases the bases that are used for salvage. So which catabolic product is uric acid, purine or pyrimidine? Which catabolism product is uric acid, purines or pyrimidines? You got to put the right intermediate in the right pathway. And then hyperuricemia may lead to gout. Why? Because high uric acid concentration precipitate as what? What does high uric acid concentration present as? Monosodium urate crystal, urate stones too, but urate crystals, which are needle-shaped, damaging, elicit acute inflammation. That's why the typical history of high uric acid levels leading to gout is swollen, tender, greater toe, because it involves distal joint and is needle-shaped. So you got to do hyperuricemia, gout, but also treatment. How do you treat acute versus chronic gout? Acute, you are going to take care of what? Acute gout. First, what would you take care of? Pain and inflammation. Then look after the uric acid levels. Uric acid levels, you can reduce the uric acid synthesis. But if the cause is renal, you can also give uricosuric drug. So the treatment also comes. So I'm not telling you not to go clinical. You got to go clinical in the end. Gout, treatment. But first you got to know, where did you get uric acid from? Does that make sense? Great, you have a lot of mnemonics. Great, keep going on. Colchicine is also causes microtubular arrest. It is also used to suppress inflammation. Gather as much as you can, right? But I'm trying to bring your attention to you go from your pathway and finish it with drugs and morphine. I would not say morphine for gout. We can debate that later. I'm just talking about what Dr. Kamath has talked. Has he talked about morphine? Okay, great. Don't confuse me like that. Anyways, so you have, when you talk about purine versus protein catabolism, be mindful. Hyperammonemia patient, you will aim in restricting protein or purine. Hyperammonemia patient, what would you want to restrict, protein or purine? Protein. That's very good. I hope you can distinguish that. Gout patients, purine. Then you go to the pathway. Rate limiting enzyme is PRPP synthetase or PRPP aminotransferase. Which one is rate limiting if you see my cursor? Is it PRPP synthetase? Yeah, PRPP aminotransferase. Purines are smart. They first activate the sugar and then they build up the ring. You bring all the sources of purine ring. Now, mistake students make, though tetrahydrofolate is required for purine ring, is is tetrahydrofolate required for pyrimidine ring? Is no. But that doesn't mean folate is not essential for pyrimidine synthesis. Where do you need folate for pyrimidine synthesis? Which pyrimidine synthesis I just taught you needs folate? Thymidine synthesis. So, okay, folate is not contributing to pyrimidine ring, it's contributing to purine ring, but that doesn't mean folate is not essential for pyrimidine synthesis. For thymidine synthesis, you need folate. Then you bring in your drugs. Parent compound IMP can form EMP, AMP, and GMP. They are all feedback inhibitors, AMP, IMP, and GMP. Why? This is called feedback inhibition. Final products are feedback inhibitor. PRPP is a universal turn on for any synthesis. De novo, salvage, purine, pyrimidine. That is universal because you cannot form nucleotide unless you add sugar and phosphate. And how do you add sugar and phosphate? In the form of, how do you add sugar and phosphate in a step? In the form of PRPP. And what's always the enzyme? What's always the enzyme when you add PRPP? Enzyme is ribosyl transferase. Absolutely, ribose transferase. But when you say the enzyme is ribosyl transferase. So this finishes your purine de novo synthesis. Then comes catabolism. Why? Because catabolism releases the bases. So which nucleotide will release these bases? Catabolism of which nucleotide will release these bases? Which nucleotides catabolism will release these two? Guanine will come from? Yeah, purine only. Then actually they are not pyrimidine, right? But which guanine will come from? GMP, and hypoxanthine from? Guanine will come from GMP catabolism, IMP. Once they are released, only 10% they go into uric acid formation. What's the enzyme to form uric acid? What's the enzyme to form uric acid? Xanthine oxidase. So xanthine oxidase, you want to keep it in de novo synthesis, purine, or purine catabolism? Purine de novo synthesis or purine catabolism? Where is xanthine oxidase? Purine catabolism. But 90%, look at this, they go into salvage pathway. So this is the normal. Let's see what happens when there is a pathology, which is HGPRT deficiency. HGPRT deficiency is linked to the Lish-Nahan syndrome. Also, do you see one more enzyme here, which is also involved in catabolism? That is known as adenosine deaminase. Adenosine deaminase deficiency leads to SCID. Yes, we have identified that too, right? And yes, I was asking you at GPRT, we have linked it to Lish-Nahan syndrome. Absolutely. So let's look at this. Great. So we are good in purine and pyrimidine. So first you do de novo, compare de novo purine, pyrimidine. But when you do de novo, after de novo, do catabolism, release bases, then comes salvage. So if there is anything wrong with the salvage pathway, what will increase in those patients? If there's anything wrong with the salvage pathway, what will increase in these patients? Uric acid. Also, another reason why when salvage is defective and there is increase in uric acid, because what will happen? When salvage is defective and if there are low products, which enzyme will turn on big time? When salvage is defective and these intermediates go low, GMP, AMP, IMP, what enzyme will turn on? PRPP aminotransferase. Either way, you will have high uric acid in patients with HCPRT or purine salvage pathway defect. So is this purine salvage, purine catabolism, purine de novo synthesis? What are we doing then on this slide? Purine salvage, purine catabolism, or purine denaturing salvage. So every pathway is different, right? They have different enzyme, they have different clinical condition. No, there is no PRPP synthetase here. There is no PRPP aminotransferase here.
No,
PRPP.
on the last question you asked, what would cut on? Would it be both? Sorry, I was typing very slow. Would it
No,
just be
it would be mainly PRPP aminotransferase because
okay?
remember, AMP, IMP, GMP are mainly turning on the rate limiting enzyme. Let's concentrate on the
Perfect.
rate limiting enzyme. So yes, PRPP aminotransferase. So now here, catabolism and diet has given you the basis and they are converted into the nucleotide. I told you, whenever you want to form nucleotide, you add sugar in the form of PRPP. Do they have different enzymes? Absolutely. And we have Leishman syndrome associated with HGPRT deficiency. Again, everywhere you go with inborn errors or enzyme deficiency, you got to look at the step. Products are low, and anything that is not used accumulates. Cofactor, any intermediate. So in Leishman patient, will PRPP be high? In Leishman patients, will PRPP accumulate? Yes, and that turns on PRPP aminotransferase and catabolism subsequently and hyperuricemia. So you got to understand the normal regulation. Is this the normal regulation? Have you learned this rate limiting enzyme? Where? Where have you learned this rate limiting enzyme? Which pathway? Salvage, purine de novo, purine catabolism. Purine, pyrimidine. I'm talking about this one. Is this pyrimidine? Purine de novo synthesis. Absolutely. This is purine de novo. And then you apply where? Where do you apply it in? Leishman patient. So you got to understand normal pathway, rate limiting step, and regulation to understand why there is hyperuricemia in Leishman patients. So they are connected. You understand my point? That's why it's important for you to first do the pathway, then get into the clinical condition, right? Is everybody good? I was just watching on the time too. Great. So are you aware of this? So yes, Leishman patients, this enzyme will be turned on big time because they accumulate PRPP and they have low IMP GMP. That leads to hyperuricemia. Hyperuricemia is more common renal than metabolic. But tell me now, when I'm enumerating all these causes, the one which you just learned is which one? Leishman patient. So do Leishman patients have hyperuricemia? Do Leishman patients have hyperuricemia? You know why? You know why? Because what is turned on big time in them? Which enzyme is turned on? Which enzyme is active in Leishman patients? Not xanthine oxidase. So no, PRPP aminotransferase, which then leads to purine de novo synthesis, purine catabolism, and then uric acid. Please, when I say Leishman patients, why they have hyperuricemia, and if you're saying xanthine oxidase, that would be wrong. What is active in them because of the disease is PRPP aminotransferase. Does that make sense? You got to understand the primary pathology, primary cause, secondary later. Does that make sense? Just out of the blue, tell me why would cancer or tumor lysis syndrome, where you give drugs to for tumor lysis, why should they give you uric acid? Why should cancer and tumor lysis drugs give you high uric acid? Why? Give me one answer. Yes, absolutely correct answer. Increase cell turnover in cancer, increase catabolism, increase uric acid. Tumor lysis, Again, you will have a lot of catabolism because you're lysing the cells and, increase uric acid. So that is why. So the key is, unless you put the right intermediate in the pathway, you will not even know why. In at least in the first three, uric acid is increasing. Uric acid increases wherever what increases? Tell me. When will uric acid increase in your body? What pathway should increase big time? Primary first. So where you will have hyperuricemia, and what will increase in your body? Primarily, purine. Okay, I'll give you a hint. Not pure, you have to be specific. Purine de novo synthesis or purine catabolism? When will you give high uric acid? You should pick purine catabolism or de novo synthesis, which is primary. Purine catabolism. I want you to relate the right intermediate to the right product. So when purine catabolism is high, like in this one, then uric acid will increase. But indirectly, because of increase in de novo purine synthesis, can uric acid increase? Indirectly. Can indirectly, because of increased de novo purine synthesis, uric acid can increase? Yes, so that is indirect. Don't forget the indirect. But first keep the direct. When you will have too much purine catabolism, then you will have uric acid in the body or in the serum. Lactate always competes with urate for excretion. Now, I am telling you again, until you know normal, you will not know abnormal. So in ADA deficiency, is there low T and B cell immunity? Both T and B, not just T, not just B. Is there low T and B cell immunity? Yes? Yes or no? In ADA deficiency, which is SCID, is there low T and B cell immunity? But you got to ask yourself a relevant why. So who will tell me in ADA deficiency why there is loss of T and B cell immunity? Why? Why? Is there any reason that both T and B cell immunity is lost in them? If you know normal, you will know abnormal. Anyone? Why is T and B cell? Anyone knows the answer so I can answer? It turns off ribonucleotide reductase. Absolutely wonderful answer. Excellent and excellent. It turns off ribonucleotide reductase. Look at this. Everything is around the step. If there's an ADA deficiency, will adenosine accumulate? Yes. So will be AMP, ADP, deoxy-ADP. I forgot to tell you in purine synthesis, I can tell you in pyrimidine de novo synthesis, please, and no, only di forms are converted into deoxy form, not mono or tri, only di, right? And did I tell you, so who will tell me what was the natural inhibitor of ribonucleotide reductase? Who was the natural inhibitor of deoxy-ATP? Is it accumulating in adenosine deaminase patients? Is it accumulating in adenosine? Yes, that's why ribonucleotide reductase is significantly turned off in them. Is it good? Very good, very good. I like your answer. Is it good that RR is turning off in them? Why? You will not have DNA. And that's why you lose the cell function. That's why the whole T and B cell immunity is lost in them. The cell cannot function if you don't have ribonucleotide reductase. So see, you got to connect. You got to connect the normal rate-limiting enzyme, its regulator, its feedback inhibitor, its activator with the disorder. Does that make sense? So this is turned off in patient with ADA deficiency, and that's not good because they will lose all the cell function, including T and B cell. Okay, so are you good? Are you following my pace? Is it helping everybody? Yes. Now let's do pyrimidine synthesis. They are not very smart. They first run for the ring, bring in CO2, glutamine, aspartate. But when you see orotic acid, you got to ring the bell. They are talking about pyrimidine synthesis. They then add the sugar. Ribosyl transferase and decarboxylase is also known as this dual enzyme. ribosyl transferase as well as decarboxylase is known as what? UMP synthase. Then it can form the corresponding nucleotides. Also look at this, please. Only which forms are converted into deoxy forms? Only which forms are converted into deoxy forms? Not mono, only di. Is there a natural inhibitor here? Is there also a natural inhibitor here, which is accumulating in ADA deficiency? Deoxy ATP, absolutely. Any deoxy form can inhibit, but deoxy ATP is the ultimate inhibitor, right? And again, did I tell you that methotrexate, do you see my cursor here? Can it indirectly inhibit thymidine synthesis? Can methotrexate indirectly inhibit thymidine synthesis? Yes, so you got to bring in your rate limiting steps, your important enzymes, drugs, direct, indirect. Direct are more important, but indirect are for good grades. Does that make sense? Is CPS2 rate limiting enzyme? Yes. What are the product of this pathway? What are the product of pyrimidine synthesis pathway? Give me the products. All pyrimidine nucleotide. Diform means monoforms will not be converted into deoxy. Triforms will not be converted into deoxy. Only diforms are converted into deoxy. This is what I mean by diforms. Only diforms are converted into deoxy forms. The products, what are you producing in pyrimidine? UTP, CTP, and deoxy TMP, right? These are your product. Yes, not nucleoside. When I say de novo pyrimidine synthesis, I'm not saying nucleoside. I'm synthesizing pyrimidine nucleotides. Does that make sense? Because you're adding a sugar and a phosphate, right? So give me the inhibitors of CPS2. Inhibitors of CPS2. Who's the ultimate inhibitor? There are any product can inhibit UTP. UTP is the ultimate inhibitor. CTP can also inhibit. Any product can inhibit, but some are very strong inhibitors. So UTP and CTP, right? So please, this is an excellent slide to bring in drugs, rate limiting enzyme. Do add activators and inhibitors, just as I told you. UTP and CTP are inhibitor of CPS2, right? If it was CPS1, who will be the activator? CPS1. Any activator? NAG. Don't nag, but nag here if you want to get good grades. Keep nagging yourself. Yes, NAG. Arginine also can activate CPS1, but NAG does that too. NAG and arginine. So are you aware of this pathway? Is this rate limiting? For what? CPS2 is rate limiting for what? You got to be specific here. Is it pyrimidine salvage or pyrimidine de novo? Pyrimidine de novo synthesis. What is this a dual activity of? 1 and 2. What is 1? Ribosyl transferase. What is 2? Decarboxylase. What is together known as UMP synthase? Absolutely wonderful. And do you have the product feedback inhibition here too, just like purine de novo synthesis? This is what I asked you. So is this feedback inhibition? UTP, CTP, are they feedback inhibitors? Yes? Yes or no? Yes, they are feedback inhibitors. And is UMP forming all the other pyrimidine nucleotide? Absolutely. Now let's do UMP synthase deficiency. So in UMP synthase deficiency, what will build up? What will build up here? Orotic acid, absolutely, it will show up in urine. And what would be low? UMP and all other nucleotides, right? So when you see, when nucleotides are low, now this here you got to distinguish. Do you see megaloblastic anemia here too? Macrocytic or megaloblastic anemia here too? Will you see macrocytic and megaloblastic anemia? Somebody saying no. Why are you saying no? Will you see macrocytic and megaloblastic anemia here? Yes, you will because of low nucleotide. But tell me, what is the cause of megaloblastic anemia and folic acid deficiency? Here, cause of anemia, macrocytic anemia is UMP synthase defect. But what is the cause of macrocytic anemia in folic acid deficiency? No, cause. I'm not saying why you get megaloblastic anemia. Megaloblastic anemia means nuclear maturation lags behind cytoplasmic maturation. I'm asking you what's the cause? No folate trap. Folate trap is seen in B12 deficiency. Because of pregnancy, low folate in diet, folic acid malabsorption, methotrexate intake. So see the cause. When you see the clinic question stem, if this was megaloblastic anemia due to folic acid deficiency, what would you see? A history of pregnant female, a history of low folate intake, a history of poor folate absorption or malabsorption, or methotrexate intake. So do you understand that megaloblastic anemia can be seen in folic acid deficiency, B12, and UMP synthase? But what should rule out? There should not be any history. If you want to pick UMP synthase, there should be no history of pregnant female, methotrexate intake, folate malabsorption, or for low folate intake. Does that make sense? What about B12? B12, you can say it's because of folate trap, but B12 deficiency, what would you see? They should at least give you additional neurological signs and symptoms, which are not seen in UMP synthase and folate. Are there specific signs and symptoms that are seen in B12 deficiency that are not seen in UMP synthase or folic acid deficiency? There are specific neurological signs and symptoms. Anybody's aware of? Paresthesia, tingling, numbness, they are not seen in folic acid deficiency. Every vitamin has a different history. Does that make sense? So additional neurological signs, some neurological signs and symptoms are seen in B12, not seen in folate. What would you see in folate? Pregnant female, low folate intake, poor folate absorption, methotrexate intake. Will you see all that in UMP synthase deficiency? Will you see methotrexate history here leading to megaloblastic anemia? So you understand what is the cause of megaloblastic anemia here? Because there is low. Are you following this or not? Yeah, so the cause of megaloblastic anemia here is not folate, not B12, but low UMP. You got to understand that. Does that make sense? Then only you will be able to distinguish, because there is a lot of vitamins here, right? Folate, B12, and you want to distinguish. Does that make sense? I will quickly do a folate B12 differential. This is my last slide, just to answer that question, because I think many students did answer. So I hope you're not confused between folate versus B12. But all I'm bringing your attention to, if you want to pick megaloblastic anemia, and it is because of UMP synthase deficiency, tell me what should be in the history. If you want to say, okay, this is megaloblastic anemia, not because of folate or B12, what should be in the history for you to pick up that this is UMP synthase deficiency leading to megaloblastic anemia? What should be in the question stem? One, low UMP. Secondly, they should say folate is normal, B12 is normal. Does that make sense? They got to tell you that folate and B12 are normal, right? Then only you will say that this is megaloblastic anemia due to UMP synthase deficiency. Yes, low UMP is also one thing. Yeah, there's no pregnancy history, no history of poor folate absorption. All I'm saying is for you to pick up UMP synthase deficiency and megaloblastic anemia, folate and B12 got to be normal. Does that make sense? Yes, right? But then how would you differentiate? So why are you doing this differential? Tell me. Why am I doing differential between UMP synthase and OTC deficiency? What is common to them? What is common to them? Both have orotic acid in urine. Absolutely excellent answer. Both of them have orotic acid in urine. But what is differentiating? Levels of UMP. Where will UMP levels be low? Left or right? UMP synthase deficiency or OTC deficiency? Where will be UMP low? UMP will be low in left, which is UMP synthase deficiency. So there will be some common finding, but there will be a differential. Here uracil is high, right? Why is uracil high here? Who will tell me why is uracil be high here? Why should uracil be high here? Why should UMP be high here? Anyone? Why on the right side? Because, very good, because in them there's nothing wrong with pyrimidine synthesis. Carbamoyl phosphate accumulating in the mitochondria is just pushing in the cytosol to do pyrimidine synthesis, because these intermediates are common to urea cycle and pyrimidine synthesis. That's why there's nothing wrong with UMP synthase here. That's why UMP and uracil very good. Very good. That's why in this case, there should be no uracil low or UMP low. Yes, this is hyperammonemia too, absolutely. So do you understand these two? So will you see megaloblastic anemia in OTC deficiency? Will you see megaloblastic anemia in OTC deficiency? No, no, and a big no, right? So what is OTC? Is it hyperammonemia 1 or 2? OTC. 2, absolutely right. And now let me do one thing, folate versus B12. Give me a second, because I think many students are confused with it, and that would be my last segment. Quickly, let's do that. Okay. And I hope this is helping. Are you seeing my folate slides? Now, are you seeing my slides now? Folate? Let's do folate versus a B12. Everybody? Yes. Okay. Am I on the right slide? Give me a second. No, first we got to do this. Right? Let's see folate versus B12 deficiency. Because when I asked you that UMP synthase deficiency, megaloblastic anemia is not because of folate or cobalamin. Are you clear with that? Megaloblastic anemia and UMP synthase deficiency is because UMP is not available. Does that make sense? Yes? Does that make sense? Great. So megaloblastic anemia can be because of folic acid deficiency, B12 deficiency, or UMP synthase. Let's see how we can distinguish that. First of all, are you aware that methionine synthesis requires both folate as well as B12? Are you aware of the fact, sorry? Are you aware of the fact that methionine synthesis requires both B12 and folate? B12 and folate, right? So in B12 deficiency, let's see. So you have macrocytic anemia due to folate, B12, as well as UMP synthase. Why you have macrocytic anemia due to folate, we'll come back to that later. But why do you have megaloblastic anemia in B12 deficiency? Because there is a folate trap. The folate is trapped as methyl tetrahydrofolate. You don't want that. So folate trap is not seen in folic acid deficiency. It's seen in B12 deficiency. Why you don't want folate trap? Because you need free tetrahydrofolate to do purine synthesis, pyrimidine synthesis, and methionine synthesis. Secondly, B12 or folic acid deficiency. What will happen to these two levels? Tell me. B12 or folic acid deficiency. What will happen to homocysteine and methionine levels? B12 and folic acid deficiency, what will happen to homocysteine, high homocysteine, and methionine, low? So does it differentiate? Does homocysteine and methionine levels differentiate folate from B12? Because yes or no? No, because in both of them, homocysteine will be high and methionine will be low, right? So let's go further. How can we help differentiate them? So that's what I told you. Do you need trap folate or free tetrahydrofolate? Do you need a trap folate or treat a free tetrahydrofolate? So now in B12 deficiency, folate is trapped. That's why you can do desynthesis. In folic acid deficiency, either in pregnant female, low folate intake, poor folate malabsorption, also you can do desynthesis. But folic acid deficiency, there is no folate trap. Please understand that. Secondly, if you are not doing these two syntheses, Do you see megaloblastic anemia, nuclear maturation lagging behind cytoplasmic maturation? When you don't do purine and pyrimidine synthesis, both in folic acid and B12 deficiency, do nuclear maturation lag behind cytoplasmic maturation? And that is why you see immature cells with large nuclei known as megaloblast or macrocyte. But in folate and B12 deficiency, will methionine synthesis also be low in both of them? In folate and B12 deficiency, will methionine level also be low? Yes, okay. So, but the problem is, so it's easy to distinguish pathway 1 from 2, right? So tell me, if it is pathway 1 defect here, what will happen to methionine levels? If pathway 1 is defective, what will happen to methionine levels? Methionine levels will go up, right? So you can easily distinguish, is it pathway 1 defect, pathway 2 defect by just looking at methionine. Is that clear? Right? But when it's only 2 defect, then there's a problem, because 2 can either be because of folate or B12. Here it is a problem. In both of them, what will happen to homocysteine? In folate as well as B12 deficiency, what will happen to homocysteine? High. Methionine, low. So how will you distinguish? You will go to the next. This is what I was asking you, that if there is a one-step defect, it's easy. You will just look at methionine levels. If there's one-step defect, methionine levels should be high. The problem is when this pathway is defective. How will you distinguish? Let's look at this. You can easily do it here. Now tell me, if folic acid is deficient, what happens to homocysteine? If folic acid is deficient, what happens to homocysteine? High. Methionine, low. But tell me, in folic acid deficiency, what happens to MMA? Normal or low? Normal. Do you understand that? In folic acid deficiency, MMA levels are not changing. So this is how you distinguish them. That's why, because this pathway will not help you. Secondly, lastly, students are confused between MMA1 versus MMA2. What is MMA1? MMA1 is this defect? Is this defective in MMA1? Yes or no? Is adenosylcobalamin defective in MMA1? So what will accumulate in MMA1? Tell me. MMA, homocysteine, or only MMA? Only MMA. What is MMA2? Adenosyl defect and methylcobalamin defect. Both are defective. So in MMA2, what will accumulate? Homocysteine, methylmalonic acid, or both? In MMA2, both. So do you understand? That is how you got to draw the different steps and understand that. Good luck.
I have a